to wake up a little bit and get engaged, I'm gonna pull my phone out because I make some notes. Not that I have to think about this. But, one of you guys, tell me a quality car brand. Let's hear it. Toyota. What else? Audi. Okay. Mercedes. Why do you pick Mercedes? Okay, fair enough. Why did you pick Audi?
Same, in honor of our new friend here today.
I asked for quality car brand. Not because I'm sure.
They are known for quality.
How do you know that they're known for quality?
That's a fair point. They're thought of, I guess, perhaps their marketing suggests.
Fair enough. Okay, so you use the word marketing. So, tell me a quality red wine.
Red wine,
Yeah, quality red wine.
spear.
How do you know it's quality?
Well, South Africa has some of the best, vineyards.
How do you know they're best?
I enjoy it so much.
Do you have any data that says that?
Well, I like it. So.
Okay, so you get where I'm going with this, right? So now, tell me a quality cancer hospital. And you're not allowed to say Christianity. Memorial Sloan Kettering. How do you know that's a quality cancer hospital?
Very well.
Experience, right? So somebody had a good experience. What are other quality hospitals or quality indicators for cancer?
And medicine.
MD Anderson. How do you know that MD Anderson is a quality hospital?
They've taken good care of me.
Okay, fair enough. So again, it's experience, right? But when we in the healthcare world talk about quality, as physicians, we're really driven by data. And so when we get reimbursed as a hospital, we're getting reimbursed based on data. Some of our CMS metrics are all based on how well the hospital is doing in terms of data. So if somebody has cancer and chooses to go to a certain facility, you choose based on, why did you go to MD Anderson, if you don't mind me asking?
I was diagnosed at Jefferson and they recommended Penn Medicine.
Okay, fair enough. So you chose because, somebody said, let's go, right? But my point is, there's not one reason why anybody in the state of Delaware needs to leave the state of Delaware to get high quality cancer care. And I can tell you that because I came from the nation's very first cancer center in Roswell Park, founded in 1898. So, but how do you know that what I'm saying is true? Well, close your eyes, and if I told you that I'm talking about a cancer service line that is affiliated with a hospital system that's been ranked 9th in-hospital mortality out of 156 large academic medical centers. If I told you that cancer service line is the only cancer service line that has a cell therapy or bone marrow transplant program in an entire state, if I told you that cancer service line is the only place that does what we call robotic Whipple surgery, which is arguably the more complex surgical procedure in the cancer world you can come up with, in an entire area comprising of 4 different states. If I told you that the research program in that cancer service line is recognized on a regular basis with names like MD Anderson and Memorial Sloan Kettering, and none of the Philadelphia programs are recognized for the clinical trial approval of that cancer service line. If I told you that cancer service line is designated by the National Cancer Institute for its quality that has to be reapplied or there's a regular application every 5 years, and has remained NCI designated as a community cancer program. And that cancer program is one of only 4 in the nation that has true basic science translational research infrastructure right up on the 4th floor of that cancer center. That cancer program is right here in Newark. Why don't you applaud? So, but let's talk about data, okay? So, if I have to be honest, and I didn't realize that this doesn't show as well, but there are no truly well-defined and agreed upon quality data metrics in the cancer world. So whenever I go to a Highmark and say we have a high-quality, high-value cancer service line, they're going to say, well, do you have data? And I say, well, we don't have any data that we can agree upon. So data in terms of cancer quality is really well ill-defined. And why is that? Payers and most other metrics are based on a one-time care episode. So if you need to have your gallbladder removed, you go, you're diagnosed, the surgeon says, let's take it out. You go to the operating room once, you never see the surgery again, maybe for your post-op visit. If you have cancer, that is a multi-year process. For most patients, it's for the entire rest of their year because of their life, because they need continued surveillance. So it's not just a one-time and done episode. It's a multi-episode time frame. And as far as we've come in the year 2026 in terms of cancer treatment, now patients live much longer. So lung cancer 5 years ago, you had a chance of dying from your lung cancer within five years at 80%. Now we can guarantee for those 80% their 5-year survival because we've come so far with our treatments. So now go to a payer and say, that same patient now needs their $120,000 a year immunotherapy treatment for the rest of their life, longer than 5 years. That's a big discussion to have with the payer, and of course they don't want to engage in those conversations. So it's longer than just a one-time care episode. And high-quality cancer care is multidisciplinary. It's not just the surgeon operating or maybe the chemotherapy doctor giving chemotherapy. A quality cancer program for most cancers requires at least 2 of those specialties, surgery, radiation, chemotherapy, to play well together in the same box in a tightly coordinated fashion. Many times it's all 3. And on top of that, you need social work, you need a special dietitian, you may need a special physical therapist. So it's really, truly multidisciplinary. And guess what? People don't necessarily recognize that as a quality metric. Well, we do provide multidisciplinary care. Care coordination. Patients, when they get diagnosed with cancer, want to know 2 things primarily, at least from where I sit. 1, what does this mean for me? Do I need to have daily chemo, daily radiation? Can I be cured? 2, are you in my corner, or am I all by myself, right? And so care coordination, we're amplifying our nurse navigation program so that every patient that touches our cancer service line first meets the nurse navigator that is specializing in that particular cancer, and that nurse navigator holds that patient by their hand, wraps a blanket of empathy around the patient and says, we've got you from the beginning all the way throughout your anti-cancer journey. On top of that, cancer care doesn't only happen within the hospital. Actually, cancer care in an ideal world should really happen where the patient is, and that is as close to the patient's home as possible, maybe even in the patient's home. So we're thinking about doing chemotherapy, not in our cancer center, but in the patient's home. Radiation we can't do yet. Surgery we certainly can't do yet, but chemotherapy we can start to think about it. And just imagine the massive degree of innovation that's currently happening in the cancer space. It's accelerating every single day, right? And how do you account for that? How do you make sure that you're always at the cutting edge of cancer treatment? That's quality as far as I'm concerned. Now, one indicator that most payers have recognized for quality is a clinical trials program. and Christiana Care has one that is par 9. The national average in terms of patients walking through the door and getting accrued into clinical trials is about 4%. At Roswell, we were struggling to hit 5%. At Christiana Care, 30% of patients are enrolled in clinical trials. The system has massively resourced the cancer program with clinical research coordinators, nurses that specialize in cancer clinical trials. And for whatever reason, we've been able to attract physicians that really are driven to provide cutting-edge treatment for their patients. And then standardization is critical. If I see Dr. X for my cancer, and Dr. X says, well, or my primary care doctor says, you should see Dr. Y, how do I know if Dr. X and Dr. Y provide the same quality of care? And so we are driving that quality of care standardization by using what we call clinical care pathways. I will be able to guarantee throughout Christiana Care's cancer care system that patients, no matter where they touch us, whether it's in Sussex County, in Middletown in our new facility, on the Newark campus, on the Wilmington campus, and even in Delco in Pennsylvania, every patient with the same problem will get the same quality of care. This is what it looks like. David. This is what it looks like to patients, to payers, to referring providers. Cancer is super confusing. Can you imagine the resources wasted in all of this? You know, one doctor says, oh, you have a pancreas tumor. For me as a urologist, I would get this all the time. Patient gets a CT scan for kidney stone, which is without IV contrast dye, and it looks like there's a massive big tumor in the kidney. The patient walks into my office thinking they're going to die. And I say, you didn't get IV contrast. Let's get an IV contrast study. Guess what? It's a benign cyst. The patient has no problem, no cancer, no nothing. But had the patient had a contrasted CT scan the first time around, cost savings, heartache savings for the patient. The point being, this is really confusing, and we need to make sure that the patient is always at the center of our entire cancer journey. So one of the indicators for quality is the quality of the health system that the cancer care gets delivered in. And Christiana Care is recognized on a regular basis for the quality of care we deliver right in our hospitals. The one mandatory meeting that we have in person every week at 7:30 on Thursdays is our Clinical Effectiveness Council, where all physician or all clinical leaders sit, and all we do is look at quality metrics on a regular basis. We didn't have a meeting like that in the nation's first cancer center. Ever. The focus on quality, the laser focus on quality in Christiana Care is still, to me, 18 months in, super impressive. And we're recognized for it on a regular basis. This is our overall score compared to 150 academic hospital system in cancer. So the point I'm making is we're better than average, but we can go far away. We have a long way to go, but we have metrics to be guided by. And so one of the challenges that I say to my boss, Dr. Anzalati, is you're going to have to hold me accountable to numbers. And these are numbers that we do have numbers that you can hold the cancer service line leader accountable to. We're starting to track the mortality for cancer patients. Now there's a lot of, let's call it misinformation in the data. We're cleaning the data up, but the point I'm making here is by the time this is all said and done in about 6 to 12 months, we will have clean data that will allow us to look and track cancer inpatient mortality for all patients that come in. And we do pretty good. This is anything green. I have ADHD and I'm a surgeon. So things have to be super simple for me. So I go by colors. But we sit in those meetings on Thursday mornings. Red is bad, green is good. When I see green, I'm like, oh, good. So this Z-score of minus 1.13 means we're below average. That's good. We're above average in quality, but below average in terms of in-hospital mortality. Same is true for length of stay. We struggle with that quite a bit at Christiana Care, to be totally transparent. The point is we're looking at the data and we're acting upon the data. So these numbers are going to improve over time, and you're already starting to see a trend down. Readmissions. When you're a cancer patient, you get sick. You get sick from the chemotherapy. And if we send you home too early and you get sick again, you get readmitted again. So CMS does not like that. The federal healthcare reimbursement body does not like patients being sent home and coming back because it costs extra money. So we're being held accountable to readmission rates. And again, the point here is that we're working on this, and we're already starting to see the impact of the last 12 months of all the work that we've done. A big focus for us, at least for me since I took over, has been focusing on the patient experience. And I want to forget my phone. And we can measure the way patients feel in their experience. And frankly, there's a lot of room for improvement for us. Care is not well coordinated. As you may know, we have two different types of chemotherapy providers in the same building under the same brand. One is our own employed phenomenal medical oncologist, and the other is a private practice medical oncology group, great friends of ours for many, many years. However, when it comes to quality metrics and patient experience metrics, I can't speak to that because it's a different world. It's a private practice. I have no insight into the quality there. So we're working very hard on figuring out how to put everything together, because to the patient it really shouldn't matter if they're walking into a Christiana Care employed and run an operated practice, or if they're walking into a branded Helen F. Brown Cancer Center practice that may be independent. Patients shouldn't have to care. Our radiation doctors have been phenomenal and groundbreaking in utilizing AI, artificial intelligence, to improve our patient experience. One of the biggest frustrations for patients is you leave your visit the first time after seeing the doctor and you have no idea what the radiation doctor talked about, what kind of radiation to get, what are the side effects, because all you hear is you have cancer, right? And so what our radiation doctors have done is they created an avatar that gets an avatar. Essentially, our chairman of radiation medicine, Dr. Adam Rabin, will come into your living room or onto your phone and will say, "Hello, I'm Dr. Rabin. I'm seeing you next week. We will likely talk about XYZ radiation treatment for you. These are the side effects. This is the benefit." And then there will be a questionnaire that will be sent to the patient. The patient will fill out the questionnaire that will communicate the patient's understanding of their treatment discussion virtually, so that when the patient physically sees Dr. Rabin can focus exactly on the areas where the patient had trouble to understand. And our experience scores, again, simple search, red, green. Our patient experience scores have skyrocketed in the radiation medicine world, simply by rolling this out over the last 12 months. So we've implemented a number of changes that will increase the quality of the cancer program at Christiana Care. The biggest change for us is what we call the assessment and treatment. Well, I call the assessment and treatment center what used to be the OEU, or Oncology Express Unit. Patients that get chemotherapy, they will run into trouble because their blood counts may start to drop, they may feel dehydrated, they get sick, they may have other side effects. They may get short of breath, they may not be able to eat or drink. So when a patient gets sick, there's two options for that patient. The patient can either call the practice and say, "I'm not feeling well, can I come in?" And then the doctor in the practice kind of eyeballs the patient and says, "Yeah, you don't look good, I'm going to send you to get a chest x-ray, or I'm going to send you to urgent care." The second option is the patient just automatically goes to urgent care or the emergency department. And then the patient sits waiting in the emergency department. And then the patient who's getting chemotherapy sits with other patients that may be having the flu or the cough or whatever. And the patient that is immunocompromised from their chemotherapy then has not only a bad, long waiting experience, they feel sick, they're scared they're going to get infected. How about we create a cancer-specific urgent care unit, or ATC, Assessment and Treatment Center? So this is housed right in the cancer center. Any patient that gets sick can call and say, hey, listen, can I come in? We have an emergency medicine trained, oncology cancer trained nurse practitioner seeing the patient, assessing the patient, working the patient out, coming up with a treatment plan. 70% of the time the patient just needs a little bit of reassurance, maybe some IV hydration, blood transfusion, goes home. 30% of the time the patient gets admitted, but gets directly admitted to the hospital without having to wait in the emergency room, being exposed to all kinds of things. So this is going to be a big change for us. The other big thing is, if you remember when I said our length of stay with regards to cancer has been a challenge, one of the challenges is that if a patient comes in with a heart attack, a stroke, a car accident, and gets a bunch of x-rays, well, you may find a bunch of things that have nothing to do with the admitting diagnosis. So there may be a lump in the chest, or there may be a lump in the adrenal gland. Most adrenal gland masses are completely benign. There may be a cyst in the pancreas. But all of a sudden, that patient then has a label, admitted for car accident, but has a potential, cannot rule out cancer diagnosis. So that patient all of a sudden becomes a cancer patient for our records. And now we at Christiana Care have gotten into the habit, historically, of, oh, we're just going to work the patient up while they're admitted for their car accident. 99% of the time, no patient needs to have their potential cancer worked up as an inpatient, as long as it's well coordinated as an outpatient. And so we implemented our incidentaloma clinic, incidental findings, that we will work up based on standardized protocols. Started last summer, and hopefully it's going to start to really show a significant decrease in our length of stay. The post-acute care transition program, you may have heard of the Hospital at Home program under Dr. Schenk's leadership. It's a similar kind of extension of that. Any cancer patient that has undergone inpatient cancer treatment that goes home, well, it's not a good thing if they get sick and then come right back. But the vast majority of patients you can anticipate trouble within the first 48 to 72 hours of their original discharge. So we're starting to implement this. These patients are being visited by a nurse practitioner at home. There's a clinical eyeball check, medication education. You should be taking XYZ medications because a wound check if the patient had a surgery. And then if the patient looks sick, the patient then can be sent to the ATC rather than the emergency department or being readmitted. Now, the one thing that I'm really proud of, and that I think has been completely underutilized, is our basic science and translational science infrastructure. We have one of only 4 community cancer programs that has built-in research lab space, and it just looks just like your college or high school experience where you put things, you pipette things, and you put things in a culture dish, and things that I used to do for my PhD. And that's called the Cawley Center for Translational Cancer Research, and my good friend and predecessor, Dr. Petrelli, who used to run the cancer service line before me, who also came from Roswell Park, by the way, is currently still in charge of the CTCI. And the two of us literally talk on a daily basis. This thing is a real deal research infrastructure. This thing is just like Penn, Jefferson, Johns Hopkins, Memorial Sloan Kettering Cancer Center, MD Anderson. It's just a tad smaller. But it allows me to attract physician scientists that right now are having a hard time being funded or getting funded at Jefferson, Penn, Fox Chase, Memorial Sloan Kettering, or MD Anderson. But the one thing that those docs all want to do is not only are they high-quality physicians, but they also want to be able to do research. So I want to move through this quickly. Not only do we have our own basic science infrastructure, but we also partnered with a clinical arm to the Wistar Cancer Institute, which is an NCI-designated Basic Science Cancer Research Institute in Philadelphia. On a monthly basis, we have interactions with these friends over there in Philadelphia, and there's really tight research collaborations going on. I already mentioned that we are accruing close to 30% of all of our patients into clinical trials. And the vast majority of those are what we call cancer prevention and control trials. So those are trials where the patient doesn't necessarily get this chemotherapy versus that chemotherapy, because let's just say it takes a lot more effort. But we can do a lot of work around, hey, listen, if you take this pill versus that pill, we can avoid your cancer from happening. So we want to build out our these top cancer research areas over the next few years. So this was it. Any questions for me?
Can you answer from the podium?
Sure.
Dr. Schwab, have you noticed any impact of federal research cuts on the work that's being done on campus?
On a daily basis, yes. Yes, I'm happy to take that conversation offline, but I think on the one hand that is our tremendous opportunity, because the larger NCI designated cancer centers are struggling a lot more than we are, and with that comes a recruitment opportunity for me. My newest recruit is starting at the end of April, comes from Roswell, is a nationally recognized cancer specialist in the colon cancer world. And one of the reasons why he's leaving is because he's just not feeling the support at Roswell, but he also sees the opportunity. This is a guy that could go anywhere, literally anywhere, but he sees the opportunity at Christianity. And so that's super exciting. And the reason why he's coming is because of our recognition for our clinical trial accrual.
Mr. Gross, about 6 or 8 slides back, you quoted a number of 54.16, which is a quality number of some sort. What does that number mean? What's, for example, Sloan Kettering and Anderson, what numbers did they get? You had your 54. Did they get a 55, or did they get an 85 or 105 or what?
That's a great question, and the answer is they're not participating in this particular audit by Vizient. So this Vizient is a national kind of consulting company, let's call it, that pulls together data on large academic medical health systems. But Memorial and MD Anderson, they're standalone, one-trick pony cancer hospitals. They're not part of the Vizient survey. So it's an important question, and the point I was getting at is we're not looking at the same, we're not comparing apples to apples when we're talking about quality, we're comparing apples to oranges.
Okay, but the question is, where do you stand relative to your best peers?
That's my point, is I can't tell you, and the peers can't tell you either. It's all about branding.
Do you have access to the numbers of your competition?
They're not being held accountable to the same numbers.
But you have other people that participate in the same survey.
Yes, so I could, for instance, tell you Emory, because it's part of this AMC, of this Vizient survey. But Memorial and MD Anderson do not participate in the Vizient survey.
What's Emory's score?
I can't tell you, but I'm happy to find out.
Thank you, Dr. Peter Horty. I have a question. I saw something yesterday, or the day before yesterday, in the paper about Medicare going to use AI to essentially change the way, maybe it's not done yet, but they're done like an experiment in 8 states, I believe, and they're talking about using AI to determine pre-existing, or whether or not the thing you're offering is acceptable for them, the AI is determining that, then apparently they have somebody who's a peer, or a human being who looks at it also. It looks like we're heading toward medical advantage plans in Medicare. What's your thoughts on that?
So AI is going to completely revolutionize the way healthcare economics are going to happen 10 years from now. We'll just have to get used to that. Right now, if I tell my patient you should have a surgery to have your kidney tumor removed versus we should just observe your kidney tumor, that's based on my experience, my training, my gut feeling, my eyeballing the patient, right? But at some point, AI will supersede a lot of that. And so when I then say you need the surgery, the insurance company needs to prior auth the surgery so that we can pay for the surgery. And right now, if there's a question about that, there's what we call peer-to-peer conversation, one doctor talking to the other doctor. And what you're referring to is a lot of the insurance companies and CMS are starting to look into, can AI replace that peer-to-peer, doctor-to-doctor conversation. But so for instance, I'm talking at an AI for Healthcare conference tomorrow in Newark at the University of Delaware. We have this big snowstorm coming up, right? We should be able to predict the need that arises out of that snowstorm for our cancer patients. I can't. I don't know if I need to staff up my cancer center at the end of next week for the ATC or if I don't, because I don't have any data. Oh wait, I do have the data, but I can't analyze it. I haven't figured it out yet. Not me, but we haven't figured it out yet. That's where AI comes in. Is that my indication for time?
I have one question, if you don't mind. You gave a statistic, and I don't remember it, about the percentage of patients that are in clinical trials at Christiana Care Cancer. How does that compare to other hospitals, or do you know?
Now that we can give you numbers to. So for instance, Jefferson, Penn, Fox Chase, none of them get above 10% of their clinical, of the patients that walk through the doors. One of the reasons being that they have competing trials for the researchers. So when I was at Roswell Park, you know, I would see my patients and then I couldn't wait to get back to the lab. When I need to talk to a patient about a clinical trial accrual, that takes extra time. That may be my partner's clinical trial that I'm not really interested in because I want to do research in my lab. So for a system like ours, in many ways, it's much easier to enroll patients into clinical trials. There's a very large, nationally recognized cancer care initiative that's called Sarah Cannon that has built its recognition for clinical trial accrual only on community doctors because they don't have any competing research interests. They just want to provide, you know, clinical trials.
Mary Beth has one quick question, if we can get a quick answer.
It's not a question, but I wanted to say, Dr. Schwab, I'm a cancer survivor and wanted to say thanks. I had stage 3 breast cancer 5 years ago. I went to Helen Graham. I met with world-class doctors and a multidisciplinary team, and they decided to do something a little experimental and not give me surgery first. I had chemotherapy first. By the time I got to surgery, the cancer was entirely gone. And so, thank you.
Thank you.
Thank you, Mary Beth. That's great. Dr. Schwab, thank you for your presentation, and it's good to hear that we've got access to awesome care right here in the state of Delaware. Excuse me. Awesome lineup coming up. So next week we are off, the last week of the month. But coming up next week, just a quick preview. We've got the February 5th breakfast meeting. We've got Andrew Catone, CEO from Eternium. He's going to be talking about clean hydrogen production right here in Delaware. February 12th, Jake Owens from Spotlight Delaware. Most of you know of him. Newly announced. We just got him in as of this morning, I think. So filling in that spot. So that's going to be an awesome presentation. And then on February 19th, we're going to have our very own Secretary of Education of the state of Delaware, Cindy Martin. So until then, take care of yourself, and if you can, someone else too.